So today I'm going to focus on hemorrhoids and fissures. This table lists some of the common differential diagnoses for anal rectal disease. Most patients who present to the office with anal rectal complaints attribute their symptoms to a hemorrhoid. So for example, a patient with a hemorrhoid may present with any of these symptoms of pain, bleeding, pruritus, discharge, lump, or mass. But the differential diagnoses include anal fissure, and as well, it's important to consider abscess, fistula, cancer, inflammatory bowel disease, anal warts, and rectal prolapse. The diagnosis of hemorrhoids is always a clinical one and should start with a medical history to identify symptoms suggestive of hemorrhoidal disease and risk factors such as constipation. You want to elicit the cardinal signs of internal hemorrhoids, painless bleeding with bowel movements with intermittent protrusion. You want to focus on extent and severity and duration of symptoms such as bleeding and prolapse, issues of perineal hygiene, and presence or absence of pain. You want to review water and fiber intake and bowel habits, including frequency, consistency, and ease of evacuation. It's important to assess fecal incontinence symptoms because this may affect your management decision. Also elicit history of recent colonoscopy and the possibility of inflammatory bowel disease or cancer. Rectal bleeding attributed to hemorrhoids represents the most common missed opportunity to establish a cancer diagnosis. The examination should be in the prone or lateral decubitus position. It should include visual inspection as well as digital rectal examination to evaluate for other anal pathology and sphincter integrity. Evaluation of the patient while straining on the bathroom will assist in diagnosis of hemorrhoidal prolapse as well as exclude full-thickness rectal prolapse. Anoscopy and proctoscopy, if needed, should be performed to assess the anatomy. There are 3 anal cushions. They're located in the left lateral, right anterior, and right posterior positions of the anus. And these are specialized, highly vascular tissue found in submucosal space, containing blood vessels, elastic tissue, sinusoids. These vascular structures can produce arterial bleeding, and importantly, they contribute to anal continence and account for 15 to 20% of the anal resting pressure. So it's really important to consider this when undertaking any treatment for hemorrhoidal disease so that you don't exacerbate any incontinence. The internal hemorrhoids are proximal to or above the dentate line, so they receive visceral innervation, but they're less sensitive to pain and irritation, so they're amenable to office-based procedures. The external hemorrhoids are distal to or below the dentate line and sensitive to pain and irritation. So these, if refractory to conservative management, should be treated under anesthesia with the exception of small thrombosed hemorrhoids, external hemorrhoids, which can sometimes be treated in the office. Dietary modification consisting of adequate fluid and fiber intake and counseling regarding defecation is the primary first-line therapy for patients with symptomatic hemorrhoidal disease. This is a grade 1B recommendation from the American Society of Colorectal Surgeons. Patients are asked to increase their fiber intake over a 4 to 6 week period in addition to increasing fluid intake. I ask my patients to increase their fiber intake by 1 scoop per day, weekly, until they see unfragmented stools or a long snake in the toilet. By bulking up the stool, straining is minimized, and fiber helps to prevent formation of other hemorrhoids even if we proceed with invasive treatment. The second part, counseling regarding defecation habits, or as one of my patients quipped, potty retraining, is just as important. Constipation and abnormal bowel habits, straining, prolonged sitting, and frequent bowel movements can play a significant role in patients with symptomatic hemorrhoids. So the dependent position of the hemorrhoids while on the toilet allows the hemorrhoids to fill with blood. So I tell my patients to spend less than 1 minute evacuating, no reading. They can get up and sit back down to evacuate. I also ask them to avoid squatting for long periods of time, for example, when gardening, and tell them to perform sitz baths in the bathtub rather than using the medical sitz bath containers that fit on toilets. I think this is the part that a lot of patients respond well to, and I think the part that I often see patients not really understanding. They understand the water and the fiber, but I think they don't understand that the reason for the water and the fiber is to help with the evacuation and the defecation habits. These two studies looked at fiber for bleeding hemorrhoids, a Cochrane review including 7 randomized trials and a total of 378 participants, compared fiber with non-fiber control and showed that fiber had beneficial effect in treatment of symptomatic hemorrhoids. 50 patients with bleeding internal hemorrhoids were randomized to receive either fiber or placebo, and after 15 days, there was a reduction in the number of congested and friable hemorrhoid cushions seen on endoscopy. Medical therapy for hemorrhoids represents a wide group of treatment options that can be offered with expectations of minimal harm and a decent potential for relief. This is a grade 2B weak recommendation. Phlebotomics is a heterogeneous class of drugs consisting of plant extracts which strengthen blood vessel walls. Cochrane review of 24 randomized controlled trials show beneficial effect, but it's not approved for use in the US. Ointments containing anesthetics, steroids, and antiseptics, prolonged use can cause allergic reactions or sensitization, so we would only recommend short-term use only for this. Most patients with grade 1 and 2 and select patients with grade 3 internal hemorrhoidal disease who fail medical management can be effectively treated with office-based procedures such as banding, sclerotherapy, and infrared coagulation. Hemorrhoid banding is typically the most effective option, and this is a grade 1A recommendation. Office-based procedures include rubber band ligation, sclerotherapy, and infrared coagulation. Outpatient surgery includes Doppler-guided hemorrhoidal artery ligation. Rubber band ligation is the most widely used technique for treatment of symptomatic internal hemorrhoids. This procedure has been available since the 1960s. After identifying the hemorrhoid through the anoscope, the rubber ring drum with 2 rubber bands are placed into the anal canal. The internal hemorrhoid is then grasped with the forceps and the tissue is pulled into the drum of the ligator. The band is placed on redundant mucosa, a minimum of 1 centimeter above the dentate line, which causes strangulation of the blood supply to the banded tissue. And this sloughs off in 5 to 7 days, leaving a small ulcer that heals and fixes the tissue to the underlying sphincter. Prior to the rubber band release, the patient should be asked whether or not there's pain, which may indicate the need to select a point higher in the anal canal. If the patient experiences intense or excruciating pain while the rubber band is in place, then the rubber band should be removed immediately. Preferred method is to band 1 or 2 hemorrhoidal columns per visit and then wait approximately 4 weeks between sessions. Studies comparing single versus multiple bandings at the same session have shown no increase in complications or post-ligation pain. Recurrence rates can be as high as 68% at 4 to 5 years follow-up, but symptoms do respond to repeat ligation, and only 5 to 10% of these patients require excisional hemorrhoidectomy. In this study of 241 patients, complications include pain in 8%, 19 patients, no thrombosis, perineal pelvic sepsis in 1 patient or 0.4%, and bleeding in 1%, 3 patients. Bleeding post-procedure occurred in 8,000 patients in this study with 2,000 rubber band ligations. 25% of these patients were on warfarin, 7% were taking aspirin or NSAIDs, and 2.9% were not taking products. I want to go back and mention that perineal or pelvic sepsis is manifested by a triad of increasing pain, fever, urinary dysfunction, or retention. These patients require ICU admission, IV antibiotics, and emergent exam under anesthesia, and debridement of all necrotic tissue. So rubber band ligation should be avoided in immunocompromised patients. Rubber band ligation compared to sclerotherapy or infrared coagulation. In this study, there was a lower recurrence rate but more pain. Rubber band ligation compared to hemorrhoidectomy. In this review, there's less pain, fewer complications, less time off work, but lower long-term cure. Sclerotherapy works best for grade 1 and 2 hemorrhoids. This office-based procedure relies on injection of chemical agents into the hemorrhoids, and this creates fibrosis, scarring, shrinkage, and fixation of the hemorrhoid by obliterating the vascularity. Agents include 5% phenol or sodium tetradisulfate. I inject about 1 or 2 cc's of the sclerosant in the submucosa of each hemorrhoid. Before I inject, I make sure the patient doesn't feel the needle, and the procedure can be used on patients, in patients on anticoagulation. The results have been conflicting. It's best for patients with grade 1 and 2 bleeding internal hemorrhoids with a success rate of up to 89%. Sclerotherapy can cause complications, including pain, impotence, urinary retention, abscess, and necrotizing infection. The occurrence rate in this study was 30% at 4-year follow-up. Infrared coagulation involves the direct application of infrared waves, resulting in protein necrosis within the hemorrhoid. It's most commonly used for grade 1 and 2 hemorrhoids, and recent randomized studies have demonstrated outcomes similar to rubber band ligation with symptom control in 81% at 6 months. Doppler-guided transanal hemorrhoidal artery ligation, or transanal hemorrhoidal dearterialization, uses a specially designed proctoscope to identify each hemorrhoidal artery blood supply, and then it's subsequently ligated. A randomized controlled trial of 337 patients with grade 2 and 3 internal hemorrhoids showed that this procedure had fewer recurrences at 1 year than rubber band ligation. The procedure is more expensive and had more serious adverse effects requiring hospitalization, 7% versus 1%. Moving on to external hemorrhoids. So patients can present with pain associated with an abrupt onset of a thrombosed external hemorrhoid. The indications for surgery include symptoms for less than 24 hours to 72 hours, inability to tolerate pain, erosion of blood clot, or circumferential thrombosis and necrosis. If the pain is intense and the patient is seen within 72 hours of the start of symptoms, then I can perform excision of the thrombosed external hemorrhoid. If the pain is subsiding, then I prefer to offer conservative management in the form of sitz baths, pain medications, stool softeners, and fiber supplementation. If the pain is unrelenting, we excise the thrombosed hemorrhoid in the office with local anesthesia. It's important to excise, not just to evacuate the clot. The wound is usually left open to heal. So operative management of hemorrhoids include excisional hemorrhoidectomy and the procedure for prolapsed hemorrhoids. With excisional hemorrhoidectomy, the hemorrhoid tissue is dissected away from the superficial sphincter. Then we suture ligate the base of the pedicle, and the hemorrhoid is excised. To avoid narrowing the anal canal, the retractor should be left in place in the anal canal until all suturing is complete, while preserving a minimum of 1 centimeter of anal derm between the columns. Strangulated hemorrhoids can arise from prolapsed 3rd or 4th degree hemorrhoids. Examination shows the rosette of thrombosed external hemorrhoids and prolapsed incarcerated internal hemorrhoids with edema. This is different in appearance from rectal prolapse, which shows not the radial folds, but more of a circumferential folds. The options for this include excisional hemorrhoidectomy via the open technique. I prefer to, if at all possible, reduce the internal hemorrhoids and to perform surgery at a later date if needed. I find that operating on these patients oftentimes leads to having to excise a lot of tissue, and anal canal stricturing can result. So it's much better and easier for the patients if we can reduce these. Sometimes that's not possible. So hemorrhoidectomy should typically be offered to patients whose symptoms result from external hemorrhoids or combined internal and external hemorrhoids with prolapse, grades 3 and 4. The grade of recommendation is 1A. It's an effective approach for patients who fail or can't tolerate office-based procedures, patients with grade 3 or 4 hemorrhoids, or patients with substantial concomitant skin tags. Meta-analysis of 18 randomized prospective trials comparing hemorrhoidectomy with office-based procedures show that hemorrhoidectomy is the most effective treatment for grade 3 hemorrhoids, although it is associated with increased pain and highest complication rate. The pain is nearly universal. Narcotics are needed to control pain, and patients usually do not return to work for 2 to 4 weeks. A randomized placebo-controlled trial found that topical diltiazem ointment, 2%, applied to the perineal area region 3 times daily, was more effective than placebo in reducing pain. Another trial found that injection of Botox reduced postoperative pain. And there are 2 randomized controlled trials showing use of liposomal bupivacaine compared with placebo, that liposomal bupivacaine showed significantly reduced pain intensity scores. The main complications following hemorrhoidectomy include urinary retention, urinary tract infection, fecal impaction, delayed hemorrhage, and pain. Urinary retention following hemorrhoidectomy is observed in as many as 30% of patients. For the procedure for prolapse hemorrhoids, a purse string suture is placed circumferentially 3 to 5 centimeters above the dentate line, and then the circular stapler is fired. The internal and external hemorrhoids are repositioned to their anatomic position after excision of a strip of excess prolapsed mucosa above the dentate line. Note that this procedure doesn't take care of external hemorrhoids or skin tags. There have been unique complications following this procedure, including rectovaginal fistula, staple line bleeding, stricture. There's a complication rate of 16% with 5 mortalities. Between 2000 and 2009, there were 40 published cases of rectal perforations with 4 deaths. Comparing excisional hemorrhoidectomy versus PPH, these 12 randomized controlled trials showed that conventional hemorrhoidectomy was more effective in preventing long-term recurrence of hemorrhoids. So in summary, these are the management options for internal hemorrhoids. Depending on the grade of the hemorrhoids, most important is changing the dietary and defecatory habits, and office-based procedures are best for the smaller hemorrhoids. So I'm going to move on to anal fissure. So an anal fissure is a tear in the anal derm distal to the dentate line, and it occurs most commonly in the midline, posterior more so than anterior. And if it's a lateral fissure, you need to suspect other causes. So atypical fissures include those caused by Crohn's disease, ulcerative colitis, syphilis, tuberculosis, leukemia, cancer, and HIV. Once the tear occurs, it begins a cycle leading to repeated injury. The pain causes the exposed internal sphincter muscle beneath the tear to go into spasm, which results in decreased blood flow, local ischemia, and poor healing. The blood flow in the anal derm of the posterior midline, which is the site of most fissures, is less than 1/2 than that in other quadrants in the anal canal. The elevation in anal pressure in patients with chronic anal fissure may result from increased tone of the internal anal sphincter, which can be demonstrated. Physical exam is important. Most fissures are readily visible by simply spreading the buttocks. Patients are often too uncomfortable to tolerate a digital rectal examination or an anoscopy. An acute fissure appears as a fresh laceration, much like a paper cut. A chronic fissure has raised edges, exposing the internal anal sphincter muscles at times. And oftentimes the chronic fissures will be accompanied by an external skin tag called a sentinel pile and a hypertrophied anal papilla at the proximal end. So I have patients who come and tell me that their skin tag is bothering them, but it's actually a fissure. So they have sharp pain, like a paper cut, bright red bleeding, and they may also complain of pruritus or skin irritation. The management depends on the etiology, but there are really three components: relaxation in the internal sphincter, fiber and increasing fluid intake, and sitz baths, which can reduce the anal canal pressure. With conservative therapy, almost half of acute fissures will heal, and topical anesthetic creams are really not more effective than fiber and sitz baths alone. The medical management includes sphincter relaxants such as nitroglycerin, calcium channel blockers, and Botox. Surgical treatment includes lateral internal sphincterotomy or advancement flap. Topical nitroglycerin increases the local blood flow and it reduces the pressure in the internal anal sphincter, which may facilitate healing. Meta-analysis of 75 randomized controlled trials found that it was better than placebo. The major side effect of topical nitroglycerin is headache in 20 to 30%. Topical diltiazem, 2%. It relaxes the smooth muscle internal sphincter. Healing was achieved in 65 to 75% of patients, and this occurs without headaches. In this study, 27 of the 41 responding patients, or 66%, remained symptom-free during a median of 32 weeks of follow-up, and 6 of 7 patients with recurrent symptoms were successfully treated with a second course. For patients who don't improve with diltiazem, I use Botox to inject into the anal sphincter, and this can be, successful healing can be demonstrated in 70 to 80% of patients. It decreases the pressures for approximately 2 to 3 months. The side effects may be mild, most commonly incontinence to flatus, which occurs at a rate of approximately 7%. And recurrent fissures can occur at 40%, but they may respond to repeat injection. Surgery should be reserved for patients in whom the anal fissures failed to heal despite adequate medical therapy. So it involves division of the internal anal sphincter from its distal-most end for a distance equal to that of the fissure. So obviously, if the patient has a fissure that extends higher into the anal canal, this may not be the best procedure. It heals approximately 95% of fissures, and the complication is fecal incontinence, usually minor, but it can persist in 6 to 30% of patients after long-term follow-up. This is the open technique, which consists of radial incision of the anal derm over the intersphincteric groove, and then limited division of the internal sphincter up to the proximal extent of the fissure, and this is performed under direct visualization. The diamond skin advancement flap can be used to cover the ulcer bed in patients whose risk of incontinence is high. So it requires isolation of a postage stamp size island of skin. It's based on a subcutaneous fat pedicle from the inner aspect of the buttock posteriorly or the perineum anteriorly. And so the ulcer is excised, leaving the defect the size of the flap, and then the flap is advanced to the open area in the anal derm and secured to the freshly cut mucosal edges. The healing rates range from 85 to 98% with no reported occurrence of new fecal incontinence. So here's a typical management algorithm. I ask my patients to take fiber, increase water intake. I give them diltiazem cream, and I reevaluate in 6 weeks. If non-healing, I ask them to repeat the diltiazem cream for another 6 weeks. And if non-healing, in certain patients, I prefer to use Botox injection. And if they're still having recurrent symptoms, we can either escalate therapy to the surgical procedures, lateral internal sphincterotomy or anal advancement flap, or a repeat Botox injection. Thank you.